This video is brought to you by the Nephrology Department at Rush University Medical Center. The procedure was filmed with consent from the patient who has been de-identified. Parts of the procedure have also been edited to preserve patient privacy. This video is intended for educational purposes only.
Hey, I'm Bill Whittier, and what we're going to discuss today is do a video session for the percutaneous kidney biopsy. I'm a nephrologist at Rush, and this is a procedure that we hold near and dear to our hearts because a lot of the history of the renal biopsy in America really started and came from Rush. If you're watching this video, you're likely a trainee somewhere along the way, either a medical student or resident or renal fellow, and this is a good sort of it's a good first step to see a biopsy in person and also go through the pre-biopsy procedures and also what we do post-biopsy. Sometimes patients will be viewing this video as well, just to get an idea of what the biopsy procedure is like before they undergo it. I want to stress that the biopsy is done in different ways. There's different methods to it. There's different post-procedure observation. And what we're going to go through today is the way that we do the biopsy at Rush. So the way that we do it is a percutaneous approach, and we do it with real-time ultrasound. This is the one that's going to be done by nephrologists. So there's already many variables along the way. The procedure can be done by interventional radiologists or other proceduralists. The procedure can be done by percutaneously with CT guided. It could be done percutaneously with the blind approach. It could be done via the transjugular approach, or even you may need an open surgical procedure depending on your bleeding tendencies. So that's beyond the scope of this video today because we're going to focus in on the percutaneous approach using real-time ultrasound. If you want to learn more about those scopes or about what to do if patients have bleeding tendencies or different observation periods, you can go to uptodate.com and read the review there on the indications and complications of the renal biopsy. So the biopsy is near and dear to our heart. We've been doing it here as nephrologists still, even though radiologists seem to be doing it more in America. We at Rush are still performing the procedure and training our fellows how to do the procedure. As I said, we do the percutaneous approach. That was really started by Iverson and Brune, and they had noticed in their first reports they were doing the procedure in a sitting position, and they noted a relatively high complication rate. Robert Kark from Rush in the 1950s brought the procedure from Europe to America and modified it to similar to what it is today. He modified it to go from the sitting position into the prone position with a sheet or a pillow underneath the abdomen to push the kidneys up closer to the surface and possibly tamponade any bleeding related complications afterwards. He published the first series of that in 1954 in the Lancet, and he noted there was a complication rate of 1 to 2%. So it was a dramatically remarkable, successful paper, and it really paved the way for the way that we do the renal biopsy today. Since that time, Dr. Corbett and myself have been publishing more and following in Kark's legacy, publishing more on trying to improve the safety and the diagnostic accuracy of the renal biopsy. And again, much of that is in the UpToDate article.
We've outlined the steps for an ultrasound-guided kidney biopsy here. This video will follow these steps with a few sections devoted to an in-depth look at the supplies and tools needed to perform the procedure.
As we said earlier in the video, what we want, and this is the modified procedure that Kark did in 1954 in the Lancet, where we actually have the patient in the prone position, and we have either a pillow or we have wrapped towels that is underneath the abdomen area, in the area of the umbilicus, which will then push the abdomen up a little bit, which does two things. One, it exposes her surface here to be in more of this shape, and the other thing is it also brings the kidneys up closer to the surface, so that you don't have to go in as deep. There may even be a tamponade effect of the kidney when it's being pushed against the back, which then possibly might help with the risk of bleeding complications. We use real-time ultrasound. Other imaging methods have been used in the past. CAT scan can be used, real-time ultrasound, and then there's the blind approach. But the CAT scan and the ultrasound have been found to be superior to those. The key with using a real-time ultrasound is that we want to see the needle as it goes into the kidney. So you want a nice stable hand on the ultrasound probe imaging the inferior pole of the kidney. Ideally, when we're part of the kidney that we want to get is the cortex, because that's where all the glomeruli are, and typically we're biopsying for glomerular disease.
The preferred biopsy approach for a native kidney is the inferior pole of the right kidney, as the right kidney sits lower in the retroperitoneal space. Therefore, it is less likely to be under the ribs. The needle ideally should be inserted and deployed across the cortex to increase glomerular yield.
So the key to this whole procedure with using real-time ultrasound is that your needle really needs to be in line with the imaging that shoots out from the ultrasound probe. So if I'm imaging here, then I need my needle to be in this plane, okay? So the needle could go in here and go out as long as this is here. If the ultrasonographer switches to this, suddenly the plane where that scar is there is the plane where the needle will go in and could then go in this way and go in on that plane. So the key to the procedure is trying to see the needle for the entire time, and to do that, you're going to want to make sure it's in line with the probe, ultrasound probe.
We've reviewed the initial steps of the procedure, so let's take a moment to familiarize ourselves with what we'll need.
Now we're going to talk about what we are going to do in the biopsy suite, and you will also see that with a patient live who's already given consent. But first we want to make sure that our materials are prepared before we go into the biopsy suite. So here we have a pretend area of all the material that has all the materials that we would need. This is a marking pen. We have our needles, including the lidocaine syringe needles, and also a spinal needle in case we need to go in for more depth. This scalpel is used to make a skin nick, and then here's our sterilizing solution, which you can use betadine, but we use chlorhexidine at Rush. Here's our lidocaine and our sterile gloves, as well as our needle, and there'll be extra 4x4s. So this requires a little bit of assistance to have someone help you, to give you the non-sterile things. But at first I'll show you here how we get the sterile gloves on. After your hands have been washed, of course, you'll put these on in a sterile fashion. And then, obviously, once you're in the biopsy suite, you also are checking in with the patient to make sure that, one, he or she is at ease, two, that you've had informed consent, three, that a timeout is being performed, and four, you're going to want to review the ultrasound beforehand to make sure there's not any anatomic variables that may preclude you from doing the procedure, such as a horseshoe kidney or huge cysts or some other reason that might, or an underlying cellulitis over the skin that you would not want to put a needle through. So first things first, we would draw out the lidocaine. So we'll get a syringe out. One of the needles is for just to make a wheel for the initial lidocaine. So that's not the one that you typically use to draw the lidocaine out of the syringe, so we'll get one of these. And again, there's different types of needles that people use at different institutions. Ours have this little pink lower lock mechanism on it that once the needle is on, you can just bring this pink part down and break it off. Then what you will do is pull that off, and I usually will take about 1 cc of air out. Somebody else will be holding this in a sterile fashion, and then we'll inject this into here, inject the cc of air into the lidocaine, and then you'll be able to withdraw lidocaine into the syringe. I usually use 30 cc's, depending on how much I think I'm going to be needing for the patient, of lidocaine. Sometimes if there's not much lidocaine that I'm going to need to be given, we may do 20 cc's. Remember, always cap in the one-handed technique so that you don't risk a needle stick to yourself. The next thing is, once you have all your lidocaine needles ready, you'll also sterilize the patient. You'll use a marking pen, as you'll see in the room, to help give you an idea of guidance. And then we'll look at the needle here. So this is the biopsy gun, which I typically don't show to patients because it's such a large needle that they get a little bit apprehensive when they see it. As I said, that these needles have changed over time. It used to be a Vim Silverman needle, but they've always been one where you have a internal hollow core which captures the tissue, and then a sheath that goes over it. These biopsy needles are not spring-loaded guns, if you will, and I'll show you how they work. The first step is to get it ready for the procedure itself. You take one button down there, and then you'll take the second button down, and then this whole part can come off, which will go in the garbage.
And now we'll return to the biopsy suite, where a timeout has been performed, the skin has been prepped with chlorhexidine, and our plane for biopsy has been marked.
And I kind of push into here to make sure that I can see where the needle would be coming into the ultrasound screen. And you can see me pushing her soft tissue down there, which will be going towards the kidney. Her kidney on the screen here will be coming into view with inspiration, and that's going to be the inferior pole coming down as the kidney does move with inspiration. The next thing that we're going to do is going to go ahead and use lidocaine. So there's different needles that go on the edge of that attach to the syringe. We usually typically will go with a 25 gauge for the wheel, a 18 gauge to draw up the lidocaine, and a 22 gauge also to inject lidocaine into the patient, as well as a spinal needle, and all these are here. So we'll take off the caps on all of them for you, take off the purple parts, and show you the needles themselves. So this one is the 18 gauge, which can be used to draw up lidocaine, or if you need it to go into the patient as well to inject lidocaine. And this is the smallest one that we start with when we're injecting lidocaine, which is to begin the process of giving the first injection underneath the skin to get a little bit of a wheel. Sometimes, not always, you will need a spinal needle, depending if you need a bit of a finder needle while you're in there. The thing to remember here is that it has a stylus on the inside, which you need to remove. And then this is your spinal needle. The other thing to remember with the spinal needle is it'll go onto the same thing, but it's a little bit more bendy or pliable. And so if you're going to go inside the patient and then you're going to move your syringe thinking the inside of the needle is going to move, the needle will actually bend a little bit. So this isn't really a good needle if you're going to have a lot of movement. If you do need a lot of movement and you have the spinal in there, you should pull out of the patient, redirect, and then inject back into the patient. Before you inject lidocaine into the patient, make sure that you withdraw so that you don't have any, that you're not injecting lidocaine directly into an artery or vein. And if you see a splash of blood that comes into that, you'll want to adjust to the point where you're pulling back and you don't have the blood returned before you inject the lidocaine in. First is the smaller needle, which what I do is I try to go a little bit away from the mark where I think I'm eventually going to go in. I'm going to use the lidocaine now, okay? So again, in the sterile field, I pull back a little bit with my skin to make it taut. I go under here so that my wheel is going to be in the area where the X is. This is the most firm part, and this is the stinging part, okay? And then switch to a slightly longer needle. And so even though I went in there for the injection site, I used this was the area where it actually is numb. And so what we'll do is then go in with this needle, injecting more lidocaine deeper. So here's more numbing medicine. Later, this will just be pressure. So the key here, yeah, there's the tip of the needle that we'll see on the ultrasound pro. The key here is that my movement of the needle needs to be in line. I pulled it back out. It needs to be in line with the probe so it can go this way, so that the whole needle goes down in the visualization of the field. If I started moving it this way, then we would lose, as the angle of the needle went in, we would only see the needle for the little 1 centimeter of the plane that the ultrasound's showing. So it's very key to this procedure of keeping in the exact same plane as the ultrasound probe. And ideally, the ultrasound probe held by our ultrasonographer stays in the ideal same position, catching the inferior pole of the kidney. It's easier said than done sometimes. Sometimes the kidney moves a little bit, and the ultrasonographer will then need to move the probe to find the right kidney. The next is the spinal needle here, which has a stylus that we removed. The spinal needle allows more lidocaine to be injected deeper. The key to this needle is that it's a little bit more pliable or bendable. So if you think you're on the inside of a tissue and you need to adjust something, you may not be adjusting, the needle might just be bending. More numbing, okay? That should be pretty well numb, but we're just going to use more. If you want to see that, Dr. Blank, on the screen, you can see the needle going towards the kidney. Dr. Schwartz, would you be able to point out the needle there? Yeah, going towards the kidney and then circle the kidney. More numbing there, okay? So after I have a good visualization with this finder needle, I want to try to remember that angle when I go in with the actual biopsy needle. Before we go in with the biopsy needle, we'll use a scalpel to make a little skin nick. I usually use a lateral skin nick so that it kind of goes in the dermatome distribution as opposed to a more vertical one. Again, I pull back and just use a little nick at the site. This, of course, is going to start bleeding a little bit more. And then you use a 4x4 to kind of tamponade it. Once the biopsy gun is in that hole or nick that you just made, it tamponades the bleeding itself so that the blood doesn't go down the side of the patient and onto the ultrasound probe. Sometimes that happens. It's not a big deal if it does.
We'll pause here to review do's and don'ts of the biopsy needle.
After this is removed, you can discard it in the garbage, and your needle, once there's 2 buttons pressed, is spring-loaded and ready to fire. The 2 mechanisms to release the needle are this button, which you would push this way, or the button on top, which you can just depress there. What depressing this or depressing this will do will allow the needle, the spring on the inside, to shoot about that much out. And what will happen is that it'll shoot out the hollow part, and then after the hollow part has captured the tissue in the middle, the sheath on the outer part will cover it. So the other issue to think about when you're firing the needle is that there is a bit of a recoil when you do a spring-loaded mechanism, typically that one you would see when you're doing a real gun as well. So if you held this up against a wall or against a table and you push the button, it would recoil up. So realize that you need to hold firm enough pressure when you're in the biopsy suite at the edge of the kidney to not have it bounce up away from the kidney. But you also don't want to hold so much pressure that you're pushing into the kidney and then firing, because if you push into the kidney and you go in this far and then you fire, you'll go through and through the kidney. A typical kidney size is somewhere between 11 and 13 centimeters, and you can see that you don't want to go too deep because the area that we're going for in the kidney is the cortex of the kidney, which is the surrounding part of it, which we'll see on the ultrasound. So this can be fired by releasing that mechanism, which then allowed it to go up another 2 to 3 centimeters, and then pull back one to expose the external sheath, and the second one to do it again. And you can see how it's the same way if you push this button, and that allows the spring-loaded mechanism to exist. So once you pull out and you have kidney on the inside there, the way to give this tissue to the pathologist is to just push down the first button here. And you can see now that there's the hollow core. The piece of kidney should hopefully be there, and you'll allow that to roll off the needle so that you can give that to the pathology technician who's in the room. The last part, in an error that I see many novice proceduralists do is they'll hold on to the needle itself, which is fine as you're holding on to it as you're advancing. But when you get ready to fire, if you hold on to it, you're going to prevent it from going in, and it won't fire in the right way. So it's very important when you're ready to fire that you have hands off of both here and you're holding the right amount of pressure on the outside of the kidney so that the firing mechanism goes into the kidney and you're not recoiling or going in too firm. The key here again with the needle is to make sure that we're double cocked before we're going in. If it's a single cock, that's a big no-no. That will lead to a misfire. We'll go ahead in, trying to be in a very similar angle to what I was with my finder needle. I think I'm a little lower than you. If you come lower, will it?
You're lower, yeah.
Okay. Okay, so I will come out. Pull it over a little bit. So I was a little lower than the angle at which I was at before, so we do need to go a little bit higher. You should feel pressure. Sometimes to localize it a little bit, you bounce the needle up and down a little so you can see if you're in it. I think I'm actually in the kidney's bouncing. Yep. Okay. And when I see it come into the screen a little bit more, I'll go ahead and fire.
That was
Yeah.
nice.
The other part of that is have a pathology technician on site so that we can confirm that the kidney is what is in the sample and that there is renal cortex there. So we'll take a look here and see if we have, we'll turn it over and see what's on the inside. And what we do is undo a tongue depressor away from the thumbs and the fingers of our very helpful pathology technician. We roll it towards ourselves like that.
Here's a closer view of the biopsy needle's deployment into the kidney's inferior pole. Next, the pathology technician will examine the tissue under a microscope to confirm the presence of renal cortex.
I'm just holding some pressure, okay, with my hand.
Okay. Looks like it's half cortex.
This is an example of what the technician may see under the microscope, with the pink circles being glomeruli. And now we'll return to the biopsy suite for the second pass.
Typically with a 16 gauge needle, 2 cores of the kidney provide adequate tissue. We've defined that in a focal disease as at least 10 glomeruli, and that's what we're going for here. Again, I make sure this is double cocked, and we'll go back in the same path that we did. Oh, that's better. Yeah, right there, huh? Okay. Again, to access the tissue, we take the top button. Sorry. You can see what it looks like on the inside of the needle core. When we try to put it here, gingerly let it fall off, rolling it towards ourselves.
The second core is examined under the microscope to again confirm the presence of cortex. If needed, a third pass can be performed if the previous samples were inadequate. Avoid taking more than 5 passes, as more than 5 passes increases complication rates. If the cores are adequate samples, you may proceed with cleanup.
About this is that we want to clean up our sharps, so we'll take all of our sharps and we make sure that they get into the sharp container, and then all of our tainted areas get in the appropriate receptacles so that we have a clean field afterwards. The last part to the patient is just applying a Band-Aid over the area where we made the skin nick. I hold firm pressure for about 5 minutes afterwards, which is possible to help tamponade a developing hematoma. We didn't see one on the ultrasound. We do a 1-hour post-ultrasound scan for screening purposes on everyone that goes through the procedure, and up to 60% to 70% can have a hematoma, but that doesn't necessarily mean a complication. It could be a silent hematoma as well. And that ends the renal biopsy procedure.
At Rush University Medical Center, after a native kidney biopsy, the patient is taken to the recovery area to await a 1-hour post-biopsy ultrasound. After the rescan, the patient is placed on strict bed rest and admitted for 23-hour observation to monitor for complications. Policies and practices outside Rush may vary widely, so please refer to your institution's guidelines and policies for post-biopsy monitoring if you are not a Rush provider.